Hello, good evening, ladies and gentlemen. A very warm welcome to Wallingford Sports Club. This is the 10th of 15 planned meetings of the big health and care consultation, the Oxfordshire Transformation Programme. My name's Gavin Gray. I'm chairing the meeting. I'm not part of the NHS. I'm a freelance journalist who used to work and live here in Oxfordshire for a few years when I was working with ITV Central and Meridian. It's my role in this meeting. We've booked this room now for a couple of hours to get as many different voices heard about the issues here around Wallingford. And to that end, we're going to have a short presentation followed by some questions and answers. The presentation, I think, will help you, at least I hope, help you formulate any concerns, questions, any ideas you may have alongside the packs which are on the table as well. And then also we'll go into some round table groups. At the end of that period, I'll ask each of the groups on those tables for their main points. And then there'll be a conclusion from some of the panel members. I'll get the panel members to introduce themselves in a moment. Just a couple of housekeeping points. No fire alarm is planned. If a fire alarm does sound, then that is the main door, as well as going out background to the bar. And the car park is the assembly area. Could I just remind you, this is a no-smoking building, obviously. And if you've got a mobile phone, it would be great if you could turn it either to mute or off. The toilets are out of that door and to the right. And those two tables have an audio loop available. So if anybody needs that, who's on this side, perhaps they could swap with somebody over there. But those two tables have an audio loop. And the meeting, the main area of the meeting will be recorded. So for anybody that's missed it as well, those will then get put up onto the website of the CCG. So without any further ado, a warm welcome to you and a warm welcome to our panel. And I will get you to introduce yourself one by one. Sula.
Good evening, everybody. My name is Sula Wiltshire. I'm the lead nurse for the Clinical Commissioning Group, and I have lived and worked in Oxfordshire since 1980.
And good evening. My name's Andrew Burnett. I'm a GP in Sonning Common, and I'm the Locality Clinical Director for the group of practices covering South East Oxfordshire for the Clinical Commissioning Group.
Good evening. My name's Andrew Stevens. I'm the Director of Strategy and Planning for the Oxford University Hospitals. So we run the three hospitals in Oxford, the Churchill, the John Radcliffe and the Nuffield Orthopaedic Centre, as well as the Banbury Hospital, the Horton General. In my role, which I've been doing for 17 years, I work with our doctors, our nurses, and indeed with our partners across the health and social care system to plan services for the population that we serve.
Hi everyone, my name's Catherine Stoddart and I'm the Chief Nurse for Oxford University Hospitals Foundation Trust, and part of my role is professional accountability for the midwives who run the MLU here and across all of the county.
I'm guessing everyone can hear that and all the microphones are working. Now, there are several ways in which people can effectively get their voices heard at this meeting. For those that are a bit too shy to ask any questions, when we come to the question-answer session, there are some postcards on the table and some pens. If you would prefer to write a question out and hand that up or ask one of the facilitators to bring that up to the stage, I would try and get that asked. Equally, of course, feel free to stick your hand up when we come to that section, or indeed through the round tables would be another way. But I have been asked at the end of a couple of meetings, how else is that it now? What happens next? All the contact details for the Oxfordshire CCG are at the back of the main brochure booklet that you can see on the tables, and I'll remind you about ways in which you can get in touch. OK, if we start off by having the presentation, and I'll hand over to Sula.
Thank you very much, Gavin. Let me stand over here. This is probably the best place to be. So good evening, everybody. That's the agenda, which I think Gavin has gone through, so I don't think we need to cover that again. So this is the consultation, and I'll explain this in a little bit, is in two parts. So this is the first phase. It commenced on the 16th of January and will finish on the 9th of April. And we are consulting on, as you can see there, the use of hospital beds, planned care at the Horton, acute stroke services in Oxfordshire, critical care at the Horton Hospital, and maternity services at the Horton Hospital. And the second phase of the consultation will be later on this year, and we'll try and explain a little bit more about that as we go through. So, why are we consulting? As you know, healthcare is not a static thing. It doesn't stay the same. It changes, and indeed our population is changing. Our population is growing, and our population is getting older. That's really positive. People are living longer. That's excellent. But obviously, in order to ensure that the services keep pace with our changing population, we need to change them to some degree and modify them. The other issue we need to consider is, whilst NHS funding is growing, it will not keep pace if we stay exactly the way we are. So it won't keep pace with the current model. So we need to think about how we use our money to best effect to ensure that we get the right healthcare for the population. We need to think much more about how we all keep ourselves well and think about the prevention agenda. So it's an area that we're never that great about in the NHS, I think. It tends to be an area that we assume will be taken up by public health, but we probably all need to get a little bit better about things that we can all do, taking sufficient exercise, eating a diet that's good for us, not indulging in too many cakes in my case. So those kind of things which we really need to think about, and also bringing prevention in much, much earlier on into children's and young people's lives, so they kind of live with that model all the way through. We do have inequalities in Oxfordshire, and we need to think about how we address that. So, for example, in Oxford City, there's a difference in the life expectancy from one side of the city to the other. So and it's quite stark. So we need to think about that and address it. Quality and safety, we can always strive to improve quality and safety, and that's what is at the heart of this consultation. How can we continue to drive up quality and increase safety for the people who use the health service? Buildings and equipment, really important, but it's having the right building, the right equipment in the right place and using it well so we get good value from that equipment. The other thing we need to think about is our workforce. The current workforce cannot continue to meet the demand that we've currently got. So we need to think about how else might we, what other kind of devices we might deploy in order to support that? How do we use our workforce to best effect? Thank you. Why are we doing...
slides available on the website or somewhere, or should I take notes?
No, they are available on the website, Sarah, and they should be on the table. You should have copies, hopefully, on the... Yes? Thank you. So, why are we doing it in two parts? Well, there's a couple of reasons for this. One, it's quite a lot. There's a lot of services to consult on. The other area was there was an urgency to some of the consultation, and the Health Overview and Scrutiny Committee required us to go out and consult, particularly around the issue of the acute beds, because there had been some work going on where changes had happened, and HOSC required us to go out to consult on that formally. Maternity services at the Horton. So at the present, there's a midwifery-led unit at the Horton. Previously, it had been an obstetric-led unit up until October last year, when unfortunately, due to the lack of obstetrician, for safety reasons, that unit had to be temporarily closed. So at the moment, it is a midwifery-led unit, and all obstetrics is delivered from the John Radcliffe. Critical care and stroke. So again, with critical care, and this is particularly at the Horton, very small numbers of patients were accessing that service. So we have to then think about the skills of the workforce and whether we can continue to maintain that model. A similar story with stroke, and Andrew will talk a little bit more about those services as we go forward. And an important point is about investing in planned care at the Horton. So as I said at the outset, healthcare does change. So some of you will be familiar. Previously, when you would have had an operation, you might have been in hospital for 5 days a week. Much, much more care can now be delivered more rapidly in a day case scenario. So we need to think how we ensure that we make the best of that, investing in planned care at the Horton. So our vision for the future, Diagnostics, so local access to diagnostics and expert advice. It's really important that when you attend a doctor or a nurse and you're unwell, we need to understand what's the matter with you. And sometimes that requires access to diagnostics. And when I'm talking about diagnostics, it's things like X-rays, CT scans, those kind of things. So trying to have that as local as we possibly can. We want to prevent unnecessary admissions to hospital. Unfortunately, every now and then, people do need to be in hospital, but we want to ensure that only those who really need to be in hospital are in hospital. And indeed, the same thing for accident and emergency. Can we deliver that care locally in a different way? The use of technology, I don't think we've really exploited this in any great way, and we probably need to think how we can use that much more effectively. I'm sure all of you in this room probably have done Skype or FaceTime or other such things. We need to think how we apply some of those technologies in healthcare. We do firmly believe that if you no longer need a hospital bed, then the best bed to be in is your own. And there's a scary statistic at the bottom there about the amount of muscle loss that happens to particularly older people when they're confined to bed. So I think at that point I hand over to Andrew. Thank you.
So I'm going to try very hard here not to fall off the stage as I wander about. So I'll share the any financial reward from television programmes if I do. Okay, so let's hit the first slide. So we're going to talk today about how we can... Here we are. So I'm going to give you an example about using hospital beds differently. What's happened up to now is that as people get old, become old and frail, they're quite often, if they go into hospital, it can quite often be very hard to get them home again. And it's a particular problem in Oxfordshire where we have difficulties with people staying in hospital when they're fit to come home, mainly because just the complexities of putting together packages of care to get people home. So we're trying very hard not to admit people into hospital in the first place, as Sula was saying. So let's hear about this.
Mum had a bit of a fall from her chair. She has dementia and she's disabled. I picked her up off the floor and it looked as though she'd had a stroke. I called the ambulance and they decided that she needed the hospital.
The Liaison Hub is a team of multi-professionals who are working together, based at the hospital, but the most of their work is actually carried out in the care home beds across the county.
Staying in hospital for the full extent of one's recovery is neither necessary nor desirable. Reducing exposure to other people who are unwell, reducing exposure to infections by moving into a hub facility increases the probability that someone's transition into wellness is going to continue without being broken up by the harms of being in a hospital environment. There's a huge psychological component to being cared for. Within 3 days, many particularly older or more vulnerable people will become incontinent, whereas previously they weren't, just by virtue of having the availability of someone to look after your most basic needs. So by expediting a transition from being in a cared-for hospital environment to a much more natural, homely environment, still within the support of a nursing home or care home, then we can make sure that we're avoiding that increased dependence which a lot of patients experience. We no longer see care as being a black or white division between pure hospital care until you're fully better and then discharged home. We don't like the idea of discharge.
Radcliffe told me we managed to find you a bed in the nursing home that your wife's in. And they said, well, just thought it'd be good companionship for you, nice and simply together. And I very much enjoyed it there. I really did.
I've seen really great results from people being enabled to get out of hospital, continue to have their rehabilitation and care, but in a setting that is much more homely. The liaison hub is a key component for ensuring that the whole system is using its capacity efficiently. I'm absolutely certain it's helping patients. The patients that I've worked with have really thrived.
The liaison hub made such a difference to us because actually it got Mum to the place that she really needs to be. I can't thank them enough. I'm really pleased with the way things went.
So the liaison hub is a great way of helping to facilitate people to get home more quickly. Now, the other thing that we're doing in this part of the world, and you're really fortunate living in Wallingford and the surrounding area, is that we have access to the Emergency Multidisciplinary Unit in Abingdon, which is a fantastic way of helping people not to get into hospital in the first place by treating people very intensely in the community on an ambulatory basis, meaning they just walk in and walk out, or sometimes just being admitted for a day or two to the local hospital in Abingdon. So that sort of change in the way we practice is meaning that old folk, and some young folk as well, are not ending up in hospital for prolonged stays. Okay, so I think we'll go on. Thank you.
Planned care is care that occurs outside of an emergency situation. And the three main components would be diagnostic tests, including imaging investigations such as CTs, X-rays and MRI tests, outpatient appointments and procedures that don't require to be performed as an emergency situation. Currently, a lot of patients have to travel to Oxford for various procedures and investigations. And if we could enhance the facilities within Banbury, then we could prevent those journeys from having to be made and try and deliver care to patients closer to their home. Looking at the catchment area of patients that travel to Oxford, it's projected that approximately 60,000 patients per year could be having their procedures and investigations in Banbury and not having to travel to Oxford for those investigations and procedures. To be able to deliver those services locally, we'd need to build a new state-of-the-art facility which would include diagnostics, outpatient facilities and improved access to certain day case surgery and routine outpatient procedures. We already perform some chemotherapy and renal dialysis treatments in Banbury, but the plan is to enhance those facilities and increase access to more patients to be treated locally. Patients often have to attend hospital for several different appointments to have their investigations and their outpatient appointments and get their results at the end. So what we plan to do with a one-stop shop is to try and reduce the number of attendances patients would have to make. So although we're trying to deliver care locally to Banbury, we also want to reduce the number of appointments patients have to make to achieve their diagnosis and treatment.
So 60,000 patients, we're trying to get 60,000 patients treated in Banbury rather than travel down from Oxford from the north of the county. But of course in the south of the county we're also investing in extra facilities and extra diagnostics. For example, the developments at Townlands Hospital, which are available to people who live in Wallingford, means that people have access to more diagnostics than they did before locally without having to go into a big hospital and deal with big hospital car parks.
At present, we have an access of all patients to the John Radcliffe for immediate assessment driven by 4 hours from onset. With the transformations that have been undertaken in stroke care in the last 18 months or so, where mechanical thrombectomy, where we use devices to pull out clots rather than just using drugs, we need to get patients to the John Radcliffe to enable equitable access from the whole county to this life-changing treatment. This is a very intensive, highly specialised intervention that very few centres in the whole of the UK can provide. And we're very fortunate that we have one of those centres here in Oxford. We also need to provide equitable access to the rehabilitation that enables the best recovery for patients. Through the early supported discharge service, which we hope to expand from the 6 postcodes it currently covers to the whole county, we hope that we will enable patients to have therapy in the comfort of their own home, enabling them to have therapy targeted and ensuring that they maximise their chances of returning to functional independence in the environment where they're going to spend the rest of their lives. And that's the whole purpose of the ESD being incorporated, early supported discharge, incorporated into this consultation. When it comes to immediate access to a hyperacute stroke unit, the major benefit to patients is the immediate assessment with specialist imaging and access to immediate specialist assessment by consultant staff, both physicians, such as myself and my radiology colleagues, where we can make the immediate decision whether mechanical thrombectomy is potentially helpful to patients. This is a decision where an immediate assessment and immediate decision really do enhance the chances of patients returning back to how they were prior to their stroke.
So this is the hyperacute stroke service is based on principles developed in places like London and elsewhere, where in London they used to have lots and lots of hospitals all taking stroke patients, all doing their best for their local community. And then they restricted the stroke services to about 8 key hospitals around London, 8-ish. What that might mean, if you had a stroke in London, you'd be driven past the door of one hospital to get to the one with the specialist service. And they found that the outcomes are much better, meaning people recovered better from their stroke. They were able to give treatments that stopped the stroke damaging people's brains so much. And so this is a great advance. And that means that we think it's really important that anyone in Oxfordshire who has a stroke is seen at the first point of call is a hyperacute stroke unit, of which the main one, of course, is at the John Radcliffe Hospital. There's also, for people in this part of the world, some of you from south of Wallingford would go to Reading for the hyperacute stroke service there. So it's really important that people with strokes are dealt with in specialist units. And the other thing is this, once people come home after strokes, the early supported discharge service means not only do people come home more quickly after a stroke, but also the outcomes are better, they recover, they get more function back after their stroke. So a good thing.
We have 3 adult critical care units at Oxford University Hospitals, one at the Horton, one at the Churchill Hospital, and one at the John Radcliffe Hospital. I suppose the levels of care reflect the complexity of care delivered to the patient and how sick they are. Level 3, which we sometimes call critical care, are for much, much sicker patients. These patients need advanced respiratory support, which is really the breathing machine, the ventilator. Critical care medicine is like everything else in life. The more you do, the more it becomes routine, and the surprises, the less they become unusual. If, as in the Horton, in the last year we had 40 level 3 patients, that means that's less than 1 patient each week, and in reality probably less than 1 patient a day. And that takes it into the numbers that makes managing them not routine, not normal business. Critical care facility at Oxford, there are about 1,900 patients there each year. So you can see immediately how the care of a critical care patient, which is never routine, but the general aspects of the care of a critical care patient becomes much, much more routine simply by having those numbers of patients.
So once again, for the patients in the south of southeast Oxfordshire, they'll use the level 3 critical care services in Reading, which we're going to continue to support as a CCG. The problem is that the small unit at the Horton just doesn't have the throughput to make it work well. That means the staff can't keep sufficiently up to date and they can't attract staff to work in it. So, and already in reality what happens is that the more seriously ill people are just taken straight to the John Radcliffe Hospital. So we're proposing as part of the proposal we're proposing, not to continue with the level 3 critical care service at the Horton Hospital. There will still be a very well used level 2 critical care service, which is just a slightly lower level of intensity for appropriate patients.
We want to provide a high quality, safe and sustainable maternity service. And although we provide a great service at the moment that I'm very proud to work for and work in, we can still do better. And if you look at women of today, we have sort of two groups of women. We've got a much fitter, healthy group of low-risk women, and we've got women who have more complex pregnancies. And actually, we want to design or update our service so that women can get the best outcomes for themselves and their babies and their families. So to do this, we need to look at the service that we provide and how we can make it better, make it more sustainable, and get the right women to go to the right teams.
The most important element of care for women in pregnancy and during labour is about making sure that they've got the right information to make the right decision about where they have their care and by whom. So that would be done in partnership with the woman and also her professional lead, which could be her midwife or her consultant obstetrician, depending on her pregnancy, and also her labour, her likely labour. So for women during the antenatal period, it's important that there's a risk assessment at the beginning of pregnancy to determine where they should have their care. So it would be about the right place with the right team. So if you've got a woman with a higher risk pregnancy, then there would be a requirement for them to have medical input as well as care from their midwife. But if they've got a low risk pregnancy, then for the majority of the women, they will have their care with their community midwife with some input from their general practitioner, which is also important.
The main challenge in maternity is recruiting obstetric doctors. So to recruit doctors, we need to make the jobs attractive, and we need to provide the doctors opportunities to train and to maintain their clinical skills. And currently, this is challenging, particularly in the smaller units. There's basically not enough clinical experience and clinical scenarios for the doctors to remain updated. Interestingly, there's a lot of information now and evidence that shows for these fit, healthy group of women, which most women are, they in fact do much better in low-risk midwife-led units. There's less clinical intervention and they get a much better experience and get home quicker with their babies to their families. However, for some other women, their pregnancies are more complex. And actually, as the health service has developed, we've now found that these women, they do better if they're under the care of more specialist teams and have a different group or team of professionals looking after them.
So already in Wallingford, we have a very well respected midwife-led maternity unit. Works really well for these lower risk women. And that's, so this is not what's being consulted on at this phase in the consultation. This part of the consultation, we're specifically looking at the maternity services in the north of the county at the Horton Hospital. And this has been precipitated by the staffing issues, as Sula has already explained. So, what's important is that women have a choice. And they have a choice between the midwife-led unit and the obstetrician-led unit. And the reason that the obstetrician-led unit is particularly important is that we need to concentrate our resources in one place. And that place, sensibly, is going to be the John Radcliffe unit. Of course, once again, for the very south of the county, Reading is still available and we'll continue to support that.
So again, I think Gavin said this at the outset, but there are a number of ways to respond to the consultation. Obviously contributing tonight, which is brilliant, but you can also write to the free post address. And on your tables there should be questionnaires, so if you want to either complete them or take them away for friends and family who may not have been able to join us tonight, that would be great. And then I think the last one is just the dates of where we're going with the consultation. And I think, again, yes, so if we just flick to the next slide, Andrew, that's lovely. So that's where we are, the 6th of March. Thank you.
Great. Okay, thanks very much, Sula and Andrew. I hope that's enabled you to formulate a few questions for the panel now. Just to let you know, we did invite local media and also the local MP. Sadly, the MP, I think, was unable to come. But any questions for the panel, please? We do have microphones around, and it would be great if you could just wait till you've got a microphone in front of you before asking. And if I could ask you as well to just give us your name when you ask the question. The lady there, yes, on the back table. Yes.
My name's Val Molam. I've got lots of questions, but I think probably my biggest question is this consultation is taking place in 2 parts. Healthcare depends on total interdependency from all services. And to ask us to respond to a Part 1 consultation about a particular set of circumstances, you talk about prevention and care closer to home. There's no mention of how that's going to happen. This is about saving money, and there's no mention of where the funding is going to come from to fund these extra services that are going to be provided to people closer at home.
All right, so why in 2 parts, and where's the money coming from? Sula.
Okay, so if I just make a start. So as we said in the presentation, there is a reason for it being in 2 parts. 1, because of the size of the consultation, and 2, because of the view of the Health Overview and Scrutiny Committee. So I absolutely recognise that it perhaps doesn't feel that coherent, particularly with people who are familiar with the health service or have had some involvement with it over the years. The second part will focus more on community services and primary care. I hope the example that we showed of the integrated hub gives you an idea of the thinking that's going on and how we hope to move forward in the future. Our colleagues in social care are working with us. We recognise there are financial constraints in social care, and indeed, as I said in the presentation, unless we make some changes, our finances won't necessarily keep pace with the rising demand. So we really have to think about how we address all of that. So I don't know if panel members want to add.
If I can just explain, the Health and Overview Scrutiny Committee is a committee of the County Council that is charged with overseeing the provision of healthcare in the county.
And can I just ask, well, Phase 2, what's the approximate timetable, just so this lady knows when?
So there's some complications in that we've got local elections coming up, so there's a period of time when we're not allowed to have public consultation. And there will be a decision made about Phase 1 probably May, June time, and then we would hope to come out with Part 2 in the autumn. I think that's correct, Sarah. I'm looking to my colleague at the back to confirm I'm correct.
Autumn of this year?
This year, yes, autumn of this year, yes.
Okay. Any more questions? Yes, the lady with the blue scarf.
I'm interested in the nature of this consultation. My understanding of consultations is that you're presenting an idea and you are then going to listen to what we think about it. It sounds a little bit like you've all decided and you're just telling us about it.
Okay.
So again, if I make a start on that. So last year we did have a number of meetings where we went out and spoke to the public. We are listening. We do want your views because obviously we've offered a perspective, but you may have an opinion, a view, an idea that we haven't even thought about. So please do. If you've got thoughts, ideas, how things might be done differently, please make that contribution. It is really important that we hear your voice.
I think the other point that I would add, as Sula said, the reason for coming out for a number of these issues is because there is a patient safety or a quality issue or a clinical sustainability issue that we felt couldn't wait. So you're right, for some of these, there aren't options. We have had to take action as a trust. For example, we no longer are able to support the obstetric deliveries at the Horton because we can't recruit doctors. Now, if during this consultation people can come up with ideas of other models of care that would enable us to keep those doctors, recruit those doctors, then we will listen. We've tried a number of things to actually recruit. We haven't been able to date, so for that reason we're still closed to obstetric deliveries. But if people come up with ideas during the consultation, we will listen to them.
Any more? There was a gentleman there. Yes, sir.
Jeremy Hutchins. Could I just take up the point that you made that a decision would be made in May, June on the phase 1? My concern is that, does that mean that the closure of the some 290 beds decision is going to be made at that point before we have had exposure to the community services that are going to be required to provide the support that would have been provided in hospital? I think this is an issue not just in this county but across the country, and I think Simon Stevens has said that there should be no bed closures until there was demonstrable investment in an effective community care.
So, in particular in relation to the trust and the closure of some of our beds, the investment has already happened. So we are, I guess, in front of that curve to some extent. So part of the investment that the trust has made with the CCG's support around developing the hub includes a range of community-based services. So one of those that some of you may have been exposed to is called HEART, and that is providing community care at home at slightly more intense care than you would normally get, say, through a social care environment. It's much more health related. And we also have invested in utilising some of our care home beds in a different way. So we provide intermediate care beds now, so that when, and the gentleman in the video is one of those examples that got the chance for about 6 weeks to go and live with his wife in the care home. But he was there for a different reason. That was to increase the intensity of rehabilitation for him so that he could then return to his own home. So the Trust, with the CCG's support, has invested in a range of different services in advance of that closure.
So why are you consulting?
Because we have to make a decision about whether it is a feasible option in the longer term. And as you rightly say, we need to make sure that our investment into community care is consistent with the amount of activity that we get. We know that we want to keep people in their home much longer. It's much safer for them. They get a better quality of care. And if we can, I guess what we have done is tested the model. And by testing the model, to be honest, we've actually had great success generally. We've done a lot of patient surveys around the activity where we've used the hub, we've used the care homes, and we've provided this intensive support at home. Great feedback from families generally who have had access to their families at home or been able to visit them in a care home. So, for example, patients have been able to go to dining rooms and rehabilitate and walk where they wouldn't necessarily be doing that in a hospital, spend some time with their family, and the feedback has been fantastic. So part of our consultation is to test this pilot and to give you some feedback on how it's working.
Yes, the lady who asked the very first question. Back to you. Sorry, just hang on. Wait for the microphone. Yeah. Hang on.
Are you going to ask me where's the hub?
Yes, and is there just one for the whole county?
No, it's kind of for want of a better term, it's a hub and spoke. So it's actually, it relies on technology. So the nurses, for example, in this, and the physiotherapists and the OTs that go out and work with the care homes and in the community are all over the county. but we actually coordinate some of it from the JR, and over time we've actually been looking at whether or not we can have them closer to facilities such as the EMU at Abingdon, so that there's a link between all the different healthcare professionals, because the activity happens out in the community, not in the hospital. The hospital is no longer just beds in a hospital, it is part of the community as well. We don't see ourselves as just being, it's a hospital without walls, we would call it.
Can I just make one more comment? You were asking for any ideas. I'm sure you've tried it with relation to the obstetricians, but could it not be made a basis for the appointment that whoever is appointed works some of the time at the ORH and some of the time at the Horton, and then you could keep the Horton going?
Unfortunately, it's a good point, and it's been made a few times to us. The sad element around the obstetrics issue is that the training places that are actually designated by the deanery, so not by the trust, were taken away in 2008 originally, was it? 12. And as a result of that, trainees are not able to work there because they're not training places. And so so for them, it doesn't count, I guess, towards their training. So it's a really unfortunate situation. That is not... we're not alone in this. Around the country itself, any of the training positions, there's about a 25% vacancy rate, and it's even higher for those trusts that where those positions aren't a training place. So if you have a training place, it's 25% vacancy. If you don't have a training place available, it's even higher.
And can I just say, you mentioned the deanery made the decision. Who or what is the deanery?
So the
and where
deanery
are they
is actually the university that accredits the courses. I'm hoping I've got this language right.
It's not quite the university. So training within this country is organised through a separate structure, and the deanery is the local representative of that training structure. And so the job of the deanery is to satisfy themselves that the doctors who are in training are developing the skills, the confidence, the competencies to come out and look after patients. And the deanery in our area, and supported by people who look at individual specialties, has said, as was said on the presentation, that the doctors were seeing so few cases that they were not able to develop the skills. And so for that reason, training designation was removed from the Horton.
So are you saying you've got no training at the Horton, but you have got training at the JR?
Yes, that's right.
But the lady at the back asked, why can't they work some days a week in one and some days a week in the other? And then they wouldn't have training places, all of them.
Because the number of training places is shrinking nationally, and so there is a desire to concentrate those in the bigger units so that they are seeing the numbers of cases they need. So that's one reason. And the second reason is quite simply because training designation was taken away from the Horton. It's done by site, not by trust. And because of that, then the trainees aren't allowed to work at the Horton because that training would not be accredited and would not add to their training programmes.
And taken away by
the deanery.
The deanery. Yes,
I think where the confusion's just coming from is when you say training, I think these people are talking about fully trained people who are already qualified. I think that's where the confusion's coming in. So we're talking about qualified people, can they work at both sites, not our trainees. I think that's where the confusion's coming in, isn't it? Yeah.
Okay.
All right.
Yeah, great.
Yes, the lady at the back with the blue scarf, and the gentleman as well, facing with his back to the wall on that side afterwards.
So, given that we've got an increasing number of people wanting to use hospital and care facilities, why is training being reduced?
I mean, so I'm afraid I'm with you on this. One of the very big weaknesses of the NHS as a whole over very many years has been its workforce planning.
Yeah.
So it is something that is a huge problem for the NHS as a whole. And so I can't give you a local answer to that. It's a national problem, as has been said.
So is that why the places aren't filled? As you said.
Well, I mean, I suppose one other point to make about and GP colleagues are experiencing staffing problems themselves, is that there are those specialties that are what we would say most intense, that involve most out-of-hours working, most antisocial hours working. So things such as obstetrics, such as A&E, are those services that junior doctors moving into training are deciding they don't want to go into. And I think it is a real issue for the NHS. So, for example, we are working with GP colleagues about the possibility of having what are called portfolio careers, where they can do a bit of GP work and do a bit of hospital work. So a number of the doctors who are staffing the service that Andrew described earlier around the hub and supporting care homes are people who are GPs who do a few sessions for us as well. And that is attractive to them. They can spread their experiences and have different experiences with different sorts of intensity of work. And so I think being more imaginative in the way that we staff some of these services is going to be absolutely crucial to addressing some of the staffing issues we're facing.
Yes, because a lot of practices have part-time doctors these days.
Yes,
that's right.
Yeah. There's a gentleman at the back in a bluey-green top there. Yes, sir.
The first thing is that we went through this long paper, and then it was from the audience that I learnt that 290 beds are being closed. I don't quite know what you're telling us about. Is there anything else you're closing or anything else that we need to know about what the plans are?
So it's not 290 beds. So far, 146 beds have been closed, with the plans for another 50 or so. So that's the current position, and that's in the consultation document.
Okay, it wasn't presented, so that's 196 being closed.
So 140 to date, plus
yes,
plans for another 50. Yes.
Yeah, so that makes 196 that are going to be, or have, or will be closed. So basically you're saying that that's going to happen because you don't have the funds for those beds, not that you don't need those beds.
So they have been, in some ways, been reconstituted into a different type of bed. So some of those beds are now, we have commissioned care home beds as an alternative way, the way that I was just talking about for rehabilitation. So although they're not in the hospital, they're in a different place. And in the same way that we have built up a range of services so people can actually have care in their own bed, we've swapped those beds, for want of a better term, so that patients can actually have the access to nursing, allied health, maybe some support of some description in their own home. So the best bed's their own bed. So there's an argument around this that it is actually a financial benefit, but the true benefit from a clinical perspective is there's plenty of evidence that shows that people restore their health faster and in fact don't get some of the kind of bad side effects of being in hospital if we can do that. So it's been reinvested.
So I would absolutely echo that. The important thing here is that that when somebody is ready to leave hospital, staying in hospital for longer than that date is basically bad for them. Okay? So we had a problem in Oxfordshire where at its peak, there were about 180 people in hospital beds or taking up hospital places in Oxfordshire who frankly didn't need to be there. And the Trust and the CCG have been working really hard using the sort of initiatives that Catherine's described to help people to get home. Now, part of it is using other beds, and for example, intermediate care beds in nursing homes as a kind of halfway house. So, and the advantage of that is that these beds are not so intensely hospital, and they're much more, of course, they're not the same as their own home. It's much better for people to go home in the first place. But for those people who are not quite ready to get back into their own home just because of a lack of care, these nursing home beds are a great halfway house. But they're far more, they enable people to be far more independent than the hospital beds used to be. So that's why we're able to reduce the number of hospital beds, because we're not keeping people unnecessarily in hospital.
So the two questions there. One is, you've talked about these integrated hubs, but we haven't really worked out, this is care in your own bed, if I understand correctly. So who are the staff and where are they going to come from, these people who previously looked after you in a hospital and now are going to be looking after you in your own bed?
So the staff in particular at the moment are predominantly from the University Hospitals Foundation Trust, the trust I come from, although Oxford Health provides some of that care. And we have actually been working with our social care colleagues to try and get some degree of integration. One of the I guess the advantages, there's two advantages. One is the intensity means that you don't need quite as many staff, and so that's helpful. But the other side effect of this, from a career perspective for some health professionals, some nurses, some allied health staff, is it's a really attractive type of care to provide, and it creates a career path that we didn't previously have. So I think over time, and it's early days yet, but I think that we're going to create opportunities for people, not just nurses, but other groups of health professionals, to do something that they don't necessarily get the chance to do. And because we traditionally see nurses caring for these types of patients in a hospital, and they're going to get the chance to care for them in their own home. And it's been quite attractive to the staff that have been recruited.
And I think, just to add to what Catherine has said, I think the other thing is about using our workforce. So Catherine talked about a hospital without walls. I rather like the idea of a workforce without walls, so that they can move across and work in any sector where the patient care is needed. And one of the advantages is supporting care homes and nursing homes. So those nurses have often felt quite isolated from the other community of nurses. This is a bridge to ensure that that isolation is reduced and those skills increased across the whole community sector.
And in fact, just to add to that, we've had some great feedback from some of the care homes that we work with, because they have felt so isolated. But because our nurses from both trusts go into those care homes, provide education and training, can provide a bit of support. So if they're worried about something, they can phone someone and say, "I'm not sure about this, what do you think?" We've had good feedback from them that they actually feel more supported. And also, in some circumstances, patients haven't had to come back into hospital where they might have previously.
Okay, so the final question is about the 196 beds. Are they all coming from the Horton? And the question that I think everybody will be thinking, well, what's going to be your needs in 5 years' time? Won't you need those beds back again?
So no, they're not all coming from the Horton. So they are spread out across our 4 sites, so the 3 sites in Oxford, as well as the Horton. I think your point about, pardon? The 4 hospitals. So it's the Churchill Hospital, the Nuffield Orthopaedic Hospital, and the John Radcliffe in Oxford, and then the Horton Hospital in Banbury. So I think your point about what are the future needs is a great point, and we will need to keep that under monitoring as we always do. I think one of the problems we've got, and I think it's been a good challenge from this consultation, is that we are not very good at describing and sizing the additional capacity that we are providing in alternative settings. So it could be the ambulatory care where, as Andrew says, people come in, walk in, are seen and can go home the same day. In some of the community settings, as we always talk about beds as being some form of as the major measure of how much of a health service you provide. As we provide more and more services out in the community in different models, we've got to find a better way of describing to you exactly what that is and what the size is and how much additional capacity we're putting in, because beds is no longer an appropriate way to measure how much healthcare we're providing in a number of settings, because we're providing them in a completely different way now from the way that it's been provided over the last few decades.
I'll give an example of that, if I may, which is, as you may know, there's a rapid access clinical unit being opened at the Townlands Hospital in Henley, with access to beds in the neighbouring residential home. Now, the average length of stay in a bed in the hospital in Henley used to be 32 days. The average length of stay of the people who are in the beds are looked after by RACU is 3 to 5 days. So that's the difference. So that's how
RACU?
The Rapid Access Clinical or Care Unit. I did say that at the beginning.
Oh, sorry.
But so it's an example of how by doing things differently, we can make much more efficient use of resources.
Is there? I'll come to you, ladies. But is there anyone who's not asked a question rather than? Well, you did as well, sort of thing. Okay. Anybody in that case? Oh yes, the lady of red there.
At the consequences of treating more patients at home or closer to their home, and looking at the wider consequences. I'm involved with a carers group in a village, And I would be very concerned that the elderly, looking after the elderly, are going to have their health and well-being impacted upon if they're asked to do more care at home. That's just one thing. Nothing new is coming out of this. You've heard it before, I'm sure. But the other peripheral impact, very, very severe one, will be the demand for more transport if people are needed to be taken from their bed at home for treatment or somewhere else. This is a real problem. They're unlikely to be able to be responsible for this themselves. Lastly, the liaison hub. Well, someone in Goring has tried to reinvent the wheel because they have told us that they would be willing to accommodate people who needed the sort of nursing you're speaking of, but I'm not aware of their being approached. They certainly didn't mention it to me. Thank you.
Okay, so thank you for those really good questions. I mean, the first 2 points you make are really well made. Carers, like a number of people who support the NHS, are a really, really important part of supporting people in the community. Transport, again, it doesn't sit with us, but we are working with local authority colleagues and will continue to make that point because, again, the point about transport and people being able to access health services has been made in other parts of the county. It is really, really important. The Goring issue, Catherine,
I may have to take that one offline, but I was just going to make the point that I think it's really important about, from a carer's perspective, that we actually work out how we can support carers with rapid response if they need it. So as someone deteriorates, we have found, I mean, it's early days, but we have found that that does help. But I think one of the things we really need to be able to do is if something is going wrong or somebody cannot care for a family member or they are not able to themselves, to be able to rapidly refer them to the right people close to home so they don't have too much transport. And that's going to take some working out. We're obviously trying to do this and working out ways to do it and trying to create a one-stop shop for patients and for carers. But over the next couple of years, I say that sounds like a long time, but this is going to get refined over time so we can improve it, I think.
Any other people who... Yes, no, I know you two, but anyone else who's not asked one yet? No, in that case, to the lady with the blue scarf. Sorry,
I understand that currently there's a waiting list for people waiting for operations. And when people are interviewed on the television, the big issue is whether they've got a bed to actually put that person in. And that's the question they say they ask themselves every morning. Have we got a bed to put this person in, or are we going to have to cancel the operation? Now, cutting beds seems suicidal.
Andrew Stevens?
I'll start. So you're right, because I have watched that television show myself. It was interesting watching. For us, we do make decisions on a day-to-day basis, but one of the key things, I think, is the element of the planned care that came out in the presentation. So what we're hoping to do is actually move a total of 90,000 occasions, so either diagnostics, day case surgery, or outpatients appointments, 60,000 of which are outpatient appointments, up to the Horton. So that does a couple of things. It's going to increase the capacity at the Horton so you don't have cancellations. It moves some of the work from the north to the north of the county for local people, kind of from, I want to say Kidlington above, but I might have it wrong. I'm not quite sure where it starts. Gives them opportunity. But the other thing it does is, of course, it frees up space in our other sites. Not both in terms of parking and access, because we haven't heard that yet, but I was waiting for it, but also about freeing actual capacity in those areas. So if we can move some of the activity, it's a lot. It's 300 appointments a day that will be moved up to the Horton. It frees up an awful lot within the trust, within the Oxford Ring Road, really.
I think the only other point I'd add to Catherine's is, in terms of our cancellation rate, yes, we have at times had to cancel, but it is relatively low. And the beds we're talking about that we've closed are our urgent beds, our medical beds, not our surgical beds. So our surgical bed capacity we are preserving precisely for the reasons you've said.
And sorry, just to be very stupid, the difference between those two types of beds is one is for an emergency and the other is for an operation that I get an appointment for.
And that's partly based on the skill set of the people that are caring for those two groups of people, either surgeons or medical doctors.
You don't want to mix the patients.
Yeah,
Ideally
absolutely.
absolutely not.
Yeah.
And yes, the lady in the beige jumper.
I'm sorry, it's me again, but there are two things. One about critical care and beds. If you're moving your critical care patients at level 3 from the Horton to the John Radcliffe, are the number of critical care beds at the Oxford Radcliffe going to be increased?
Yes, at the John Radcliffe and at the Churchill. We're only talking, if you remember, 40 patients a year. So that's less than one a week, and we are opening additional capacity at the Oxford sites.
Okay, and my other question is about the beds that you are purchasing in nursing homes across the county. We all know, because it's splashed across the news and the newspapers, about the lack of care in the community and the delayed discharges from hospital. Surely, by taking some of the nursing home beds, you are reducing the capacity of nursing home beds around the county.
So the answer to that is no. That it's interesting. The same question came up at Henley on Thursday, and we had the Director of Adult Social Care who reassured us that there is no shortage of nursing home capacity in the county, and that typically at any one time there can be up to 200 beds vacant.
Okay, so then why do you have that number of delayed discharges that you talked about earlier? If there's care available in the community, why are there that number of delayed discharges still in hospitals?
Delayed discharges aren't all about social care. There's a whole variety of reasons. In fact, one of the biggest reasons for delaying discharge is about people choosing or being very specific at where they want to go. The number of delayed discharges has been reduced by this initiative.
Yeah.
So we are reducing the numbers of delays.
Okay. It may make sense, Phil. Sorry.
Sorry, I could just see that you were thinking that. So we have reduced our number of delayed discharges because we've had care homes. We've utilised those care homes in a different way. And it's not quite half, but it's been a significant drop. I can't say exactly what it was today. But, of course, there are other reasons why people are delayed. And it's not necessarily that they're waiting for a care home bed.
Yeah, I was going to say it is quite a complex picture.
Yeah.
So there's a number of reasons why people may be delayed in hospital. It may be waiting for a social care package. It may be a choice issue. It may be a family that just hasn't made a decision, hasn't come to the point where they've recognised a parent has got much older, frailer, all of that. So there are a number of reasons. It's not a one problem kind of thing that you're trying to solve. Like all of us, the population who are delayed in hospital are quite complex, like most people.
Okay, I'm just aware that without wishing to see the same face, there are quite a few people who haven't asked, and that possibly the best way to hear from everybody might now be to break into the round table groups. On each table, there will be a sort of mini chair, a facilitator, and also a note taker. And if we sort of do this for sort of half an hour, I guess, or see how we go, the sorts of things that we're very keen to hear are, has the case for change been made? What would the impact be on you and your relatives? What ideas do you have to mitigate those issues? And lastly, any ideas that you may have or concerns to share. So on each table there should be now or a facilitator and a thing. And obviously the panel are probably going to mingle in amongst as well.
Mingle.
Yes. We're mingling.
Okay.
Mingle on.
Okay, ladies and gentlemen, this clock is a little bit slow, so it is actually 1:45, just after 1:45 now. If I could just bring everyone together. I think what we'll do is we'll have time to hear, say, the main point from each table, but don't worry, the rest is all going to go back into the system and to the CCG, to answer those points. And then we'll have a couple of concluding statements and just a reminder about how to get in touch with the CCG at the end. From that far table, does Andrew, do you want to give, what was the main point there? Do you have a microphone? I think you should.
Yes, I'm working. Okay. Several points came from our table. One was that there remains, I suppose, uncertainty about the prospect of reducing the bed numbers. There was a sort of lack of confidence that it's actually going to work. It's probably true. One of my table raised a very good point. Is that, okay, we know that there's going to be eventually 190 odd bed closures. Well, what proportion of the total existing beds is that? What's the denominator?
15%
We think it's 15%.
Yeah, okay.
We've got 10% over here.
10%. Okay. And also the comment that a lot of what we've been talking about relates very much to the north of the county, and so it's left some uncertainty as what will phase 2 mean for us when it is maybe changes that might affect us all more.
Okay. Lots of nodding going on in various other tables about those comments. Jonathan.
So we started off talking about the case for change. I think people felt that the direction of travel that's being described is something that we absolutely want. I think some similar points about wanting to know that it's realistic, it's viable, we can quote examples from it and so on. The key thing we came back to again and again, I think, was about health and social care. So a lot of the discussions we had, for example, were about care homes and what role care homes could play in all this. Of course, much of that is delivered in the private sector. A lot of it is paid for through a different funding stream altogether. And I think people felt that we needed to have a much clearer picture of how health and social care were going to be brought together and services delivered as one.
Okay, and Gareth.
Thank you. So I did well, and we had our one key point agreed on the table, but after that there was a really good discussion at the end, really, which was, so I'm gonna go for 2. So the point at the end was about process and how we're running this. So we've got people around the table who've experienced both now the single room panel questions for the whole 2 hours, and then also this round table event. So I think there's recognition that there's value in both of those. So I think there's an interesting challenge, I think, for how we run the rest of these, to see how we can get the best of both in all the events that are still to come, really. But the one main point to take away that we did agree on as part of the process links to some of the concern we've heard about the phases of the consultation. And it's really the concern around the changes we're proposing in phase 1 may have a domino effect on some of the other services around the county. So I think that's a challenge we need to pick up in terms of how we move through phase 1 and considering the outcomes of phase 1 and decision making, and we continue the work around phase 2 as well to make sure we can provide some assurance around those issues.
And Sula.
Thank you. So I think it's fair to say that our table touched on a number of the issues that colleagues have already mentioned. So we talked about the need for clarity and transparency in our language. So sometimes the language we use makes it appear as though things are not quite as they seem. So we've got to get better at getting our message across to the public. They didn't like phrases like ambulatory, which made it sounded like a long walking queue, and things like thrombectomy. So we'll try and get colleagues not to use those kind of phrases. We did talk about the need for information. So we had a very good example about when an older person is discharged from hospital, there's a number of things they might need: wheelchairs, showers, etc., etc. Is there a one-stop shop place where somebody could go and get all that information, or could it be all pulled together in one place? Lovely examples from one of our smaller communities about having local champions who can point people in the right direction, so a local knowledgeable person. And we also talked about the challenge of parking, which may not have been mentioned already, and also the the interfaces with the Royal Berkshire. It's really important for the population that they understand what's around, so we'll try and ensure that the Royal Berkshire are with us when we come out again to talk to you. And we also touched on the population growth, particularly around Didcot, and what we were doing to ensure that healthcare facilities were available there.
All right, so all the notes taken by the various note takers on the tables will go back to the CCG. So it's not just those main points that have been brought out that are going to be notified. As I said, we've got about sort of 6-7 minutes late before we run out on the room time, as it were. I just ask a couple of the panel members if they want to do a summing up. And you might as well do it from here. It's probably a bit friendly. Dr. Andrew Burnett, a GP from Sonning Common.
I've had a really good time, actually. It's been we've had it's fair to say a spirited discussion on this table, and I think we've had really good questions and good points raised by everybody. I think there's been some interesting themes, and I do take the point as the user of the word ambulatory that we need to make sure our language remains appropriate. I think any change raises uncertainty, and any proposals for change make people feel anxious, and I can assure you that we wouldn't all be doing this unless there was a real challenge facing us. And I think that the CCG recognises that the money, if we just keep spending it the way we are, just isn't going to last. And I think there was a sort of, one of the things we got on our table was a sort of, well can't you just ask them, tell the government it's no good, we need more. And we are, in my role in the CCG, I'm a kind of public servant, and I'm working with the CCG, and I'm responsible for that nice man, Mr. Hunt. And so, in the end, we have to do what we're told. If you want to change health service funding, please feel free to contact your MP, who I know is very interested in your views. But in the end, the CCG and the Oxford University Hospitals Trust and Oxford Health and people have to work with what we're given. And the challenge for us is to make sure we cut our cloth accordingly. And yet also we want to make sure that we continue to improve the healthcare facilities for our people we look after. And I think the people, senior people from all these organisations are here today because we want to make things better. We want to do the best we can. And I think that all the points you've made have been taken down. And one of the questions that also came up was, well, does it make any difference? Isn't this a paper exercise? Actually, no. We are actually here because what you say makes a difference. And you definitely influence us. And, I guess the proof of the pudding will be when the final report comes out.
Thank you. And Sula Wiltshire, the lead nurse in Oxfordshire CCG.
So, like Andrew, I think it's been really helpful. I'm really, really grateful to everybody, both for the questions and for their contribution. They're really open contribution to the difficulties we have. I think the public do understand the challenges that face us, and I think we need to get better at ensuring our public are better informed, and I think that is part of the language that we use, but it's also how can we get the public involved at a much earlier phase. And I think we also had some lovely ideas around the table of how we use communities to encourage them to be active in their management of healthcare. One of the comments that I didn't make earlier, but older age is a little bit more somewhat slower than a pregnancy, and we need to think about how we plan for older age, and that's across a number of sectors. It's not just healthcare, but it is with our local authority colleagues and how we make housing fit for people to stay in their own home into an older age. And again, they're things we need to really think about. So I think it's been a great event. I really would like to thank you all for your contributions. As Andrew has said, none of us like change particularly, but there is one thing I've learned in the health service: the only thing that's constant is change in the health service. So as long as we keep talking to one another and trying to understand people's perspectives, then I think it can only be a positive. So thank you all.
All right, thank you. Just to finish things off, you'll see there's the list of the remaining meetings left. The next one is going to be on Thursday at Chipping Norton from 6 until 8. Now, I'm not obviously proposing that everyone's going to go over to Chipping Norton or whatever, but The consultation does not stop. Good, see you there. The consultation does not stop, for those in Wallingford, does not stop here and now. Please take these booklets with you. They do contain at the back the ways in which you can now keep in touch, get in touch, and find out some other information about what's going on. And to the gentleman who asked about the beds, it's page 17 if you didn't find it. OK, is that the lot? Thank you very much.